This is the story of the one. As head of maintenance at a concert hall, he knows the show must always go on. That's why he works behind the scenes, ensuring every light is working, the HVAC is humming, and his facility shines. With Grainger's supplies and solutions for every challenge he faces, plus 24/7 customer support, his venue never misses a beat. Call quickgrainger.com or just stop by. Grainger, for the ones who get it done.
With Robinhood, not only can you trade individual stocks and ETFs, you can also seamlessly buy and sell crypto at low costs. Trade all in one place. Get started now on Robinhood. Trading crypto involves significant risk. Crypto trading is offered through an account with Robinhood Crypto LLC. Robinhood Crypto is licensed to engage in virtual currency business activity by the New York State Department of Financial Services. Crypto held through Robinhood Crypto is not FDIC insured or SIPC protected. Investing involves risk, including loss of principal. Securities trading is offered through an account with Robinhood Financial LLC, member SIPC, a registered broker-dealer.
Imagine stepping into a situation where someone is in profound distress, perhaps a danger to themselves or others. Your usual tactics for conflict resolution they aren't working.
Right.
What if, entirely unbeknownst to you, this individual is actually navigating a mental health crisis? It's a stark, often terrifying reality, and here's where it gets really unsettling. Individuals with severe mental illness are an astonishing 16 times more likely to be killed when approached by law enforcement than other civilians.
16 times. That statistic alone, it really underscores the gravity of the situation, doesn't it?
It's staggering.
The key insight here for anyone listening is that we're not just talking about, isolated incidents. We're witnessing a systemic failure where traditional policing tactics designed for criminal behavior are tragically misapplied to mental health crises.
And escalating danger for everyone involved.
Exactly.
Welcome to the Deep Dive. Today we're taking a deep dive into the critical topic of crisis intervention training, or CIT. Our mission is to unpack the complexities of mental health crises, understand their profound impact on individuals and society, and explore the proven strategies that empower first responders to de-escalate, connect, and guide people towards help, not incarceration.
And we'll be drawing from essential training materials and, some cutting-edge research that really highlight the origins, goals, challenges, and frankly, the remarkable successes of CIT.
And this isn't just about law enforcement, is it?
Not at all. You'll gain surprising facts and powerful insights into how a deeper understanding of mental illness can transform crisis interactions, enhance safety for everyone, and foster much-needed trust within our communities.
It's really about building a more compassionate and effective society as a whole, one interaction at a time.
That's the hope. That's the goal. #TagTagged1Reboundia, a urgent call for crisis intervention training, CIT.
So let's unpack this urgent call for crisis intervention training. The starting point is undeniably the escalating problem. Law enforcement increasingly finding themselves on the front lines of mental health crises.
That's absolutely right. Law enforcement agencies are seeing an increasing demand for their officers to respond to individuals experiencing serious mental health crises. The critical challenge is that traditional police training has historically focused on managing conflict, right? On applying force to control dangerous situations.
Standard procedure in many ways.
But when you're dealing with someone experiencing a mental health crisis, their behavior isn't typically criminal or malicious. It's often born out of profound distress, confusion, maybe a distorted reality.
And that's precisely where traditional tactics often fall short, or even worse, become counterproductive.
Yeah, they can escalate a volatile situation instead of de-escalating it. And the statistics here are, they're truly disturbing.
We're talking about a population that makes up less than 4% of U.S. adults. Individuals with severe mental illness.
Yeah.
Yet they account for at least a quarter of all fatalities involving law enforcement. That's huge disparity.
It is a massive disparity. To put that into sharper focus, the Treatment Advocacy Center reported that the risk of being killed when approached or stopped by law enforcement is an astonishing 16 times higher for individuals with untreated serious mental illness than for other civilians.
16 times higher. Just let that sink in.
And this isn't just about fatal encounters. Consider this. 1 in 3 individuals transported to hospital emergency rooms for psychiatric crisis are taken there by police.
1 in 3.
1 in 3. This isn't just an occasional occurrence, it's a significant routine burden on the system, indicating that police are often the first and sometimes the only line of response.
Wow. And the numbers go on, don't they? Investigative findings from 2015 indicated that 25% of fatal officer-involved shootings involved subjects displaying signs of mental illness.
A quarter of them.
And what's particularly tragic is that many situations start with families calling for help. just hoping to get a loved one transported to a facility for care.
Right, they're desperate.
But these situations can tragically escalate into deadly force encounters, often due to a perceived threat from something the person might be holding, like a knife or even just a household object.
And the heartbreaking question then becomes, for families and communities, could other de-escalation tactics have been used? Could this have ended differently?
Exactly. And a significant underlying factor contributing to this whole problem is what's called deinstitutionalization.
Ah, yes, deinstitutionalization. This was a policy shift that, while maybe well-intentioned on some level, led to the closure of many residential mental health facilities without adequate community mental health resources being put in place to pick up the slack.
So people were left stranded, essentially.
Pretty much. The result: instead of receiving treatment, many individuals ended up incarcerated. Estimates suggest that 40,000 to 72,000 people currently in prison nationwide would likely have been in mental hospitals in the past, according to the APA.
40 to 70,000.
It effectively shifted the burden from a healthcare system to the criminal justice system, which was, frankly, entirely unprepared to handle it.
That's a staggering number, and it truly highlights the systemic nature of this issue. But thankfully, this crisis spurred a critical movement for change.
Right.
Tell us about the spark for crisis intervention training, its origins.
Okay. The concept of CIT originated in Memphis, Tennessee, following a really tragic incident in September 1987. White Memphis police officers responded to a 911 call about a young African-American man with a history of mental illness who was cutting himself and threatening suicide.
A desperate situation.
Absolutely. The officers, trained at the time to respond with deadly force when their lives were in danger, confronted the man and demanded he drop his weapon. He became more upset, ran at them, leading the officers to open fire and kill him.
Such a devastating outcome, and clearly a signal that the existing approach was critically flawed.
It was, and this death, particularly with its racial overtones, became the undeniable catalyst. A year later, CIT was created as a direct response, recognizing that a fundamentally different approach was desperately needed, one focused on compassion, understanding, and crucially, de-escalation.
That's a powerful origin story. And it led to crucial legislative mandates, right? Like here in Texas, Senate Bill 1849.
Yes, SB 1849, championed by Senator Whitmire, was instrumental. It formalized key requirements that ripple through law enforcement training even today.
What did it do specifically?
Well, it required law enforcement officers to learn de-escalation techniques specifically to reduce the use of force. That was huge. It also established an easier process for individuals with mental illness or intellectual disability to receive personal bonds, aiming to keep them out of jail.
Trying to break that cycle.
Exactly. These changes and others regarding training requirements were specifically outlined in amendments to Section 1701.253 of the Occupations Code. It was a significant step in codifying the need for specialized intervention, moving beyond just reactive force to proactive care.
So, with this urgent problem identified and a legislative push, what exactly is the mission of CIT? What does it truly aim to achieve?
The primary goal of CIT is pretty clear: to calm individuals with mental illness who are in crisis and then refer them to appropriate mental health care services, rather than funneling them into the criminal justice system for incarceration.
So help, not handcuffs, basically.
That's a good way to put it. It's about getting them help, not punishment.
That sounds like a truly holistic approach. What are some of the other key objectives that round out this mission?
Well, the objectives are quite broad and interconnected. They include lessening injuries to both officers and the person in crisis. That's paramount for everyone's safety. Yeah. There's also a strong emphasis on promoting the decriminalization of individuals with mental illness and actively working to reduce the pervasive stigma associated with mental disorders.
Which is huge.
Huge. CIT encourages a team approach and crisis response, educating officers on how to identify behaviors that may indicate mental illness and providing them with de-escalation skills to mitigate violence and increase overall safety. And finally, it provides crucial information on how to safely transport individuals in mental health crisis to the appropriate resources or facilities,
ensuring they get the care they need.
Right.
And at its core, what's the underlying principle driving all of this? Is it simply about being, nicer?
Not really, no. Ultimately, crisis intervention training is foremost about officer safety.
Okay.
But it achieves this safety not by escalating force, but through education and the practical application of de-escalation techniques. When officers are better equipped to understand and respond to these situations, using communication and patience as their primary tools, everyone is demonstrably safer.
So it's strategic.
It's a strategic approach to safety, not just a compassionate one, though compassion is definitely part of it.
That makes perfect sense. And it leads us to the tangible impact and measurable results of CIT, which are truly remarkable, aren't they? It's not just theory.
They really are. Research indicates that CIT has a transformative effect across the board. It positively impacts officer perceptions of individuals with mental illness, decreases the need for higher levels of police intervention, significantly reduces officer injuries, and, crucially, redirects individuals from the criminal justice system to the healthcare system.
Getting them actual treatment.
Exactly. And officers themselves rate CIT very positively. They note increased exposure to and familiarity with mental illness, which in turn genuinely improves their skills and preparedness in these complex encounters.
That's a huge shift in attitude and approach. But does it translate to concrete data on reduced use of force? That's what everyone wants to know, right?
Yeah, absolutely. And the data is compelling. A Northwestern University study of the Houston Police Department found that officers responding to calls designated as CIT-related were a staggering 82% less likely to use their guns than on other types of calls.
82%? Wow.
82%. That's a massive, undeniable difference. And in another impressive example, the Bixar County Sheriff's Office in San Antonio, they train nearly 90% of their 1,430 sworn officers.
Okay.
From 2003 to 2009, their unit used force over 50 times a year. After implementing CIT training from 2009 to October of that study period, they used force only 7 times total.
7 times total, down from 50 a year.
Exactly. And this program didn't just save lives. It saved the county nearly $100 million over 8 years in associated costs like lawsuits, injuries, things like that.
82% less likely to use guns and saving $100 million. Those numbers speak volumes about the practical power of this training. What about the broader benefits for the community?
Well, beyond those impressive statistics, CIT also reduces complaints against officers, lowers financial liability, and decreases the number of lawsuits. But perhaps most importantly, it increases public trust and confidence in law enforcement among people suffering from mental illness, their families, and the community at large.
It's truly a win-win.
It really is. And this is why 46 of the 50 states now have CIP programs. It really highlights its recognized value and effectiveness nationwide. It's becoming a standard, not just an exception.
Now, to truly appreciate the impact of CIT, we need to delve deeper into what a mental health crisis actually is. So let's start by defining crisis and its common triggers.
Okay. When we talk about a crisis in this context, it's far more than just, having a bad day. The dictionary defines a crisis as a paroxysmal attack of pain, distress, or disordered function, or an emotionally significant event or radical change of status in a person's life.
A major disruption.
A significant, often overwhelming disruption to their normal functioning.
That sounds incredibly intense. What kind of emotional fallout can a person in crisis actually experience?
Individuals in crisis often feel profoundly confused, alarmed, overwhelmed, desperate, hopeless, helpless, enraged, or terrified, just a whole storm of difficult emotions.
Yeah.
And what's crucial for first responders to understand is that a person in crisis is often prone to acting instinctually, primarily focused on self-preservation rather than with logical thought.
So fight or flight kicks in.
Exactly. So non-compliance in these situations might stem from these intense emotional and cognitive factors rather than being an intentional act of defiance. It's their brain reacting, not necessarily them deciding to be difficult.
That's a key distinction right there. What are some of the common causes that can trigger these crisis situations?
Many factors can precipitate a crisis, often overlapping. Common personal losses like the death of a loved one or even a beloved pet can be profound triggers. Life disruptions like getting locked out of a house or car, a layoff or termination from work, significant financial difficulty, or major relationship issues like divorce, separation, child custody battles. These are frequent triggers. Legal difficulties can also quickly push someone to a breaking point.
So a combination of personal and external pressures, creating a kind of perfect storm.
Exactly. External factors can significantly escalate things. These include unmet expectations, lacking a sufficient support system, or being disconnected from crucial sources of support. And substance abuse, that's a very common factor that can exacerbate or directly trigger a mental health crisis.
Blurring the lines sometimes.
It really does blur the lines between a mental health issue and a drug-related incident. It's important to remember that reactions to crisis vary widely due to individual, environmental, cultural, and circumstantial factors, especially for someone with an existing mental illness where emotions or thought processes might already be disrupted.
With that understanding of crisis, let's turn to demystifying mental illness itself. What exactly is it, and how do we combat the persistent stigma surrounding it?
Okay. Mental illness, as defined by NAMI, the National Alliance for Mental Illness, is a condition impacting a person's thinking, feeling, or mood, affecting their ability to relate to others and function daily. The Mayo Clinic adds that it becomes an illness when those ongoing signs and symptoms cause frequent stress and significantly affect a person's ability to function daily.
And experiences differ widely.
Right, absolutely. It's crucial to understand that experiences differ greatly even with the same diagnosis.
And how is mental illness actually diagnosed? And what about the term insanity, which we hear so often in popular culture? Is that the same thing?
Good question. No, they're very different. Mental illness is diagnosed by qualified professionals, psychiatrists, psychologists, licensed counselors, social workers, most commonly using the Diagnostic and Statistical Manual of Mental Disorders, the DSMV.
Okay.
Now, insanity, that's a very different concept. It's a legal term, not a psychological one.
Oh.
It refers to an unsoundness of mind that prevents someone from having the mental capacity required by law or releases them from criminal responsibility. Its definition varies by state, but the key takeaway is that it's about legal culpability, not a clinical diagnosis.
That distinction between a psychological and a legal term is so important, especially when first responders are on the scene. And then there's the heavy burden of stigma, which seems to warp perceptions and make things so much harder for people.
Absolutely. Stigma is a mark of disgrace or shame. It involves labeling, stereotyping, creating divisions, that us versus them mentality, and ultimately discrimination.
And the term mental illness itself can be part of the problem.
It can, unfortunately. It can perpetuate false information, suggesting it's all in your head or a sign of weakness, thereby separating it from physical illness. Yet a vast body of research shows physical, measurable brain changes associated with many mental illnesses.
So there's a biological basis.
A biological component, just like heart disease or diabetes, it's not all in your head.
What about the common and frankly dangerous misconception that people with mental illness are inherently dangerous?
That's one of the most damaging stereotypes out there. The common belief is that people with mental illness are dangerous and unpredictable, but statistics simply do not substantiate that.
Really?
Really. In fact, only about 3–5% of violent acts can be attributed to individuals with a serious mental illness. The reality is quite the opposite. People with severe mental illnesses are over 10 times more likely to be victims of violent crime than the general population.
10 times more likely to be victims. That's a shocking reversal of the common narrative.
It is. News stories often inaccurately link mental illness to violence, fueling this false belief, perhaps as a way for people to distance themselves from heinous acts by labeling the perpetrator as mentally ill.
What are the broader, devastating consequences of this pervasive stigma?
The consequences are severe. Stigma leads to individuals refusing to seek treatment for fear of being labeled. It can cause isolation due to shame and embarrassment. Discrimination in the workplace is rampant job loss, lack of promotion, social exclusion.
Even getting insurance coverage can be harder.
Often, yes. Health insurance coverage for mental illnesses is frequently more limited compared to physical illnesses. Many struggle to access consistent treatment and resources, partly because there's no one-size-fits-all solution, and the path to effective care can be long and discouraging.
And the statistics on prevalence and the significant treatment gap are truly staggering, revealing just how widespread and underserved these conditions are.
They really are. In 2015, an estimated 43.4 million adults in the U.S. had a mental illness within the past year. That's about 17.9% of all U.S. adults, roughly 1 in every 5 people.
1 in 5.
1 in 5. These conditions range from mild to severe. While the majority live productive lives, about 1 in 25 adults, or 9.8 million people, experience a serious mental illness annually that substantially interferes with major life activities.
It's more common than many major physical diseases, isn't it?
Yes. Mental illnesses are more common than cancer, diabetes, heart disease, or AIDS. Yet, and this is the kicker, nearly 2/3 of all people with a diagnosable mental illness do not seek treatment.
2/3. That's a huge number of people, including young people, who aren't getting the help they need. Why is there such a substantial gap in treatment?
There are multiple interconnected reasons. Practical barriers include lack of health insurance, the high expense of medications, and simply a lack of access to consistent mental health treatment.
Just the logistics can be overwhelming.
Totally. Then there are the personal experiences, like unpleasant side effects from medications, weight gain, severe constipation, sexual dysfunction, feeling dissociated or floaty. Long-term, high-dose use can even lead to neurological damage.
And people stop taking meds when they feel better, right?
Yeah.
That's a common issue.
It's a huge issue. Individuals often discontinue medications when they start to feel better, mistakenly believing they no longer need them. This abrupt cessation is a primary cause of crisis incidents that law enforcement often responds to.
It's a complex picture of barriers, making the need for first responders to understand this even more urgent. Now, let's talk about deinstitutionalization's lingering shadow, which seems to be a root cause of many of the issues we're discussing.
Deinstitutionalization, yes. It was a policy of relocating people with severe mental illness out of residential mental health facilities and subsequently closing many of those facilities. Crucially, this process often failed to provide substitute support medication, stabilization, therapy in the community.
So the support structure vanished.
Essentially, this policy shift starting around 1955 contributed to a dramatic increase in incarceration. Between 1980 and 1995, the total number of individuals incarcerated in American jails and prisons increased by a staggering 216%, while the general population grew by only 16%.
That's a stark contrast. So the criminal justice system essentially became the de facto mental health system.
Precisely. Many mentally ill individuals are now routed through the criminal justice system instead of the mental health system. The number of mental hospital beds per capita in the U.S. is lower now than it has been since 1850.
Since 1850. Wow.
And this shift also created a kind of false economy. Major cuts to public mental health services in 2003, for instance, led to police calls about people in psychiatric crisis jumping from fewer than 11,000 to over 27,000 by 2012.
So any savings were wiped out by increased policing costs.
Completely eradicated any expected monetary savings. While treating a mentally ill person in a mental hospital is more expensive monthly than imprisonment, mental health treatment can prevent future incarcerations, making it the more long-term, cost-effective option for society as a whole.
An investment, really.
It's an investment that pays off in reduced crime and increased community well-being.
This leads directly into what sounds like a truly vicious cycle. Homelessness, mental illness, and victimization.
Indeed. These issues are deeply intertwined. A 2015 survey found that 25%, that's 140,000 individuals of the American homeless population, were seriously mentally ill at any given time, and 45%, 250,000, had any mental illness.
So nearly half had some form of mental illness.
Yes. More people with untreated severe psychiatric illnesses live on America's streets than receive care in hospitals. Studies certainly suggest a direct correlation between the decreasing availability of psychiatric hospital beds and increases in crime, arrest rates, and homelessness.
And they stay homeless longer.
They do. Homeless persons with mental illness tend to remain homeless longer due to isolation, significant barriers to employment, low income, poor physical health, and critically, more contact with the legal system, which often leads to criminal records affecting housing and employment prospects.
And it seems they're incredibly vulnerable to crime themselves, often becoming the victims.
They are, in the most extreme ways. People with serious mental illness are over 10 times more likely to be victims of violent crime than the general population.
Again, victims, not perpetrators.
Exactly. A 2014 analysis reported lifetime rates of victimization from 74% to 87% among homeless individuals with serious mental illness. They are 4 times more likely to be victims of violent crime than the general population.
Why is that?
Often because they live in high-crime areas and may be unable to make safe decisions like avoiding dark streets due to their condition. So the myth that people with mental illness are violent is not only false, but completely obscures the reality that they are far more likely to be the victims of violence.
Let's delve even deeper now into the specific conditions that first responders might encounter. It's crucial to understand that mental health conditions exist along a continuum, right? Not as simple on or off switches.
That's a vital point. Mental health conditions vary from mild to moderate to severe. Some are chronic, long-term, while others are acute, immediate. Symptoms can also fluctuate over time, and it's very common for conditions to co-occur. For example, individuals often suffer from substance abuse issues alongside other mental health conditions.
And all this info is based on the DSMV.
Yes, all the diagnostic information we're drawing from today is sourced from the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, 5th edition from 2013.
Okay, so let's start with personality disorders, which are described as enduring, often inflexible patterns of thought and behavior.
Yes, a personality disorder is a pervasive, inflexible pattern of thinking, feeling, and behaving that deviates markedly from cultural expectations. This affects self-perception, emotional reactions, interpersonal relationships, and impulse control.
And this can lead to interactions with the law.
It can. Individuals with personality disorders may interact with the criminal justice system because their distorted way of thinking and perceiving their environment and others can potentially lead to law-breaking behaviors. These disorders often co-occur with mood disorders, depression, anxiety, and substance abuse.
Causes them.
It's believed to be a combination of environmental factors like childhood instability, abuse, neglect, poor peer relationships, and genetic factors.
What are some of the key types that peace officers might frequently encounter, and what are the telltale signs?
We can highlight a few key ones. First, paranoid personality disorder. This is characterized by a pervasive distrust and suspiciousness of others, interpreting their actions as deliberately threatening.
Always assuming the worst.
Pretty much. These individuals are reluctant to confide, quick to anger, and have a high need for control. They might appear rational initially, but can quickly become combative, stubborn, or sarcastic, making de-escalation a real challenge.
And how about antisocial personality disorder? I think the common understanding of antisocial is quite different from the clinical definition, isn't it?
You're absolutely right. Clinically, antisocial personality disorder refers to a pervasive pattern of disregard for and violation of others' rights occurring since age 15. This manifests as rule-breaking, deceitfulness, lying, using aliases, conning others' aggressiveness, consistent irresponsibility, a notable lack of remorse, and an unwillingness to accept accountability.
And it's not just like criminals.
No, this diagnosis can apply to a gang member just as easily as to a Wall Street executive, highlighting the continuum of severity and function.
That's a critical clarification. What about borderline personality disorder? That one often gets misunderstood too.
It does. Borderline personality disorder involves a pervasive instability in interpersonal relationships, self-image, emotional expression, and poor impulse control. Individuals may make frantic efforts to avoid abandonment, exhibit a pattern of unstable relationships marked by idealizing and then devaluing partners.
Like a roller coaster relationship.
Very much so. And they might engage in self-damaging impulsivity like excessive spending, promiscuous unprotected sex, or substance abuse. They may also have recurrent suicidal behavior, poor anger control, and intense emotional overreactivity.
And it doesn't mean they're borderline something else.
Correct. It's important to clarify that borderline personality disorder does not mean someone is almost experiencing another mental illness, like borderline schizophrenia. That's a common misunderstanding. It's its own distinct diagnosis.
Good to know. And finally, narcissistic personality disorder. What should officers look for there?
Narcissistic personality disorder is marked by persistent grandiosity, a profound need for admiration, and a lack of empathy. These individuals exaggerate their achievements, expect special treatment, and often exploit others.
A sense of entitlement.
Definitely. They may believe in special powers or that they are a chosen leader, which can even connect to delusional thinking. They often demonstrate arrogant, haughty, or judgmental behaviors, which can complicate any interaction where their perceived authority is challenged.
So those are the enduring patterns of personality disorders. Now let's pivot to mood disorders, where the challenge isn't a fixed personality trait, but the often volatile swings in someone's emotional state, a very different landscape for first responders.
Yes, mood disorders are defined by disturbances in emotional reactions and feelings, where one's emotional experience is inconsistent with their circumstances. These are believed to stem from a complex imbalance in brain chemistry, often with a genetic component, and can be triggered by environmental factors.
What are the primary types of mood disorders we should understand?
The two most common types encountered by law enforcement are depressive disorders and bipolar disorders. Depression itself comes in common forms. Major depressive disorder, which is an intense level of depression lasting at least 2 weeks.
More than just feeling sad.
Oh, much more. And dysthymia, which is a form of chronic, persistent, low-grade depression that, while perhaps not as intense as major depression, can quietly drain someone for years. Depression is one of the most common mental disorders in the U.S.
And it affects more women?
It affects nearly twice as many women as men. with an average onset in the mid-20s. It can also be a natural reaction to trauma, loss, or change.
And what are the symptoms of depression that might be visible, particularly in a crisis situation?
Common symptoms include prolonged feelings of hopelessness, helplessness, or excessive guilt, a profound loss of interest in usual activities, difficulty concentrating, low energy, and an inability to enjoy pleasurable activities.
Physical symptoms, too.
Yes. There can also be significant appetite and sleep changes, sometimes leading to weight loss or gain. And it's crucial to note the direct connection here to suicide risk, as these feelings can become overwhelming.
Then there's bipolar disorder, which often involves extreme shifts, creating a particularly challenging situation for everyone involved.
Yes, bipolar disorder involves cycles between extreme activity and emotional highs, known as mania, and periods of profound depression. Impulsivity is often the primary reason for law enforcement interaction.
What kind of impulsivity?
Behaviors like exhibitionism, shoplifting, substance abuse, or other illegal activities. What's fascinating and problematic is that individuals often only seek professional help during the depressive phase because the manic phase can feel very pleasant, energetic, and creative.
So they don't see the mania as a problem.
Often, no. They might feel great, highly productive, making them believe there's no issue, even though their judgment might be severely impaired.
So what do those two phases actually look like to an observer? The depressive and the manic.
Okay. The depressive phase is similar to major depression. Prolonged sadness, hopelessness, guilt, worthlessness, difficulty concentrating, lack of interest, low energy, fatigue. The manic phase, however, involves poor insight and judgment, which can lead to severe financial problems, relationship damage, job loss, legal issues, homelessness.
And the science?
Key indicators include an abnormally high, joyful, angry, or irritated mood, inflated self-esteem, a decreased need for sleep, being much more talkative than usual, racing thoughts, and excessive risk-taking. Each phase typically lasts at least 4 days, creating these significant emotional roller coasters.
It's clear how challenging those cycles can be. Moving on to thought disorders, which distort reality. These sound particularly disorienting for the individual, like their own mind is turning against them.
They are extremely disorienting. Thought disorders include psychosis or a schizophrenia spectrum diagnosis. Psychosis itself involves a distortion of reality, often accompanied by delusions and hallucinations.
And these feel real to the person.
Utterly real. Active MRI scans have shown that the same neural pathways are engaged during auditory hallucinations as when hearing real voices. So their brain is literally processing it as reality, making it incredibly difficult to convince them otherwise just by saying it's not real.
Can you elaborate on these delusions and hallucinations? What's the difference?
Sure. Delusions are fixed false beliefs maintained despite overwhelming evidence to the contrary. These can be bizarre things that couldn't possibly occur in real life, like believing aliens removed all their organs but they still function.
Okay, that's definitely bizarre.
Right. Or they can be non-bizarre events that could occur, like believing their phone is tapped by the FBI or that people are out to get them. For an officer, dealing with a non-bizarre delusion can be particularly tricky because it sounds plausible on the surface.
I can see that. And hallucinations.
Hallucinations are distortions in sensory input. Hearing, seeing, feeling, or smelling things not apparent to others. Auditory hallucinations are the most common hearing voices. These can make it incredibly difficult for someone to focus on a conversation, hear, understand, or respond appropriately, as they are genuinely distracted by internal stimuli.
What other symptoms might indicate a thought disorder that an officer could potentially observe?
Additional symptoms include a reduction in emotional expressiveness, a flat affect. They might exhibit nonsense or rambling speech, often called word salad, where speech is jumbled and illogical. Also confusion, a limited ability to follow instructions, decreased comprehension, a disheveled appearance may be malodorous, many layers of clothes, inappropriate attire, and appearing to respond to things that aren't there, like listening to unheard voices.
That's why I like a process, making interaction very complex. Now let's move to cognitive disorders, which directly challenge thinking and memory.
Right. Cognitive disorders involve a significant decline in one or more cognitive areas. These include attention, the ability to sustain focus, executive function judgment, decision-making, short-term memory, learning from mistakes, learning and memory itself, language comprehension, perceptual motor skills like coordination, and social awareness like reading social cues or facial expressions.
And what are some specific cognitive disorders that officers frequently encounter?
Delirium is one. It develops rapidly over hours or days and can be drug-induced, medication-induced, or due to a medical condition like an infection. It includes attentional deficits, memory deficits, disorientation, and often an inability to comprehend speech or follow instructions.
Okay, and then dementia and Alzheimer's.
Yes, dementia and Alzheimer's disease. Dementia is a group of symptoms caused by brain disorders involving a degeneration of mental functioning, thinking, memory, reasoning. While memory loss is common, it alone doesn't mean someone has dementia. And importantly, it's not a normal part of aging, though it becomes more common with age.
And Alzheimer's specifically.
With Alzheimer's disease, a specific type of dementia, wandering, is a major concern. 6 out of 10 people with Alzheimer's will wander, risking serious injury or death if not found within 24 hours.
How might law enforcement interact with individuals with dementia or Alzheimer's? I can imagine this presents unique challenges.
Absolutely. Common scenarios include car accidents or erratic driving due to confusion or diminished abilities. Officers might encounter false reports, someone reporting a theft after misplacing items, or tragically mistaking a family member for an intruder.
Oh, wow.
Yeah. Indecent exposure can occur if someone forgets social norms. Shoplifting might happen because they simply forget to pay due to memory impairment.
Those are incredibly sensitive situations. What are the best communication strategies for officers in these cases?
Officers should speak clearly and concisely, resisting the urge to speak loudly. Using simple yes or no questions can be helpful if language comprehension is difficult. Nonverbal or written prompts can also be tried.
Patience seems key.
Patience is paramount. The person is likely acting out of fear, confusion, or even delusional thoughts, not intentional resistance. Providing reassurance of their safety is vital. Checking for identification, like a safe return ID bracelet, can provide critical contact info. And resources like the Aging and Disability Resource Centers, ADRCs, are available for assistance too.
We also need to discuss traumatic brain injury, or TBI. This has become increasingly prevalent, hasn't it, especially with military personnel returning home?
Indeed. Traumatic brain injury is caused by an impact to the head, rapid brain movement, blast injuries, blunt force, or penetrating injuries. It's a leading cause of death for those under 45 and the second leading cause for those over 65.
And there are different levels.
Yes, TBIs are classified by severity. 75% are mild, 22% moderate, and 3% severe. Mild TBI is most common among civilians, while moderate TBI is more prevalent in the military. It can cause moderate to severe decline in life satisfaction and significantly affect a person's ability to maintain employment, relationships, leisure activities.
And the military connection is significant.
Very. There's been a significant increase in TBI rates among military personnel, particularly during OIOEF deployments. Over 33,000 military service members were diagnosed with TBI in 2011 alone. That highlights a serious ongoing concern for veterans and their families.
That's a powerful connection to the next condition we need to cover. Post-traumatic stress disorder, or PTSD, which represents the echoes of trauma.
PTSD is a condition that develops after a person is exposed to a traumatic event, actual or threatened death, serious injury, or sexual violence. It can also occur in witnesses to such events.
How common is it?
Approximately 8 million adults in the U.S. have PTSD annually. It affects women more frequently. 10% develop it in their lifetime, compared to 4% of men. Factors influencing it include the intensity, frequency, and duration of the trauma, the individual's perceived control during the event, their emotional reaction, and their level of social support afterwards.
And what are the key symptoms for PTSD that first responders might observe in a crisis situation? What does it look like?
There are 4 main symptom clusters. First, intrusion symptoms. Recurrent unwanted memories, images, dreams, feeling or acting as if the event is happening again, flashbacks. Intense distress at reminders of the trauma.
Reliving it.
Constantly. Second, avoiding symptoms. Efforts to avoid distressing memories, thoughts, feelings, people, places, anything related to the trauma. For example, a veteran might avoid eye contact or talking to someone in uniform.
Okay. What else?
The third cluster is negative changes in mood and thought patterns. Persistent negative beliefs, self-blame, survivor's guilt, persistent fear, horror, shame, guilt, anger, loss of interest in activities, inability to experience positive emotions. And the fourth is increased arousal and reactivity. irritability, heightened startle response, recklessness, hypervigilance, difficulty concentrating, sleep disturbance, fatigue.
Hypervigilance.
Yeah.
Constantly scanning for threats.
Exactly. For someone with PTSD, safety is the primal concern, triggering that fight or flight response. Hypervigilance can make individuals perceive ambiguous information as dangerous.
So triggers are literally sensory stimuli that can transport someone back to that traumatic moment.
Precisely. Triggers are sensory stimuli, people, places, sights, sounds, smells, textures, that recall a traumatic memory and subsequently cause a physiological reaction. These can be incredibly potent and immediate, leading to an unexpected outburst or withdrawal.
And rates are high in veterans.
Significant rates, yes, particularly from recent conflicts like OIFOBF, the Gulf War, and Vietnam. And many veterans may suffer from both PTSD and TBI, creating a complex dynamic impacting mood, emotion, behavior, and thought processes.
And within the military, there are specific types of trauma that can be particularly damaging, aren't there? Like moral injury.
Absolutely. Moral injury is damage to one's conscience from acts that violate moral or ethical codes, killing or harming others, witnessing death, giving or receiving orders causing death. The emotional impact includes shame, guilt, regret, anxiety.
And survivor's guilt.
Survivor's guilt is another factor, feeling responsible when others die and you survive. It can definitely exacerbate PTSD symptoms. And military sexual trauma, MST, unwanted sexual touching or harassment, is particularly insidious because it's often perpetrated by a trusted peer or superior, adding betrayal to the trauma.
How does PTSD connect to the criminal justice system? Are veterans more likely to get arrested?
There's a clear link. Since the Civil War, there's been an increase in post-war veteran crime. Following Vietnam, nearly half of vets with PTSD were arrested or jailed at least once. More recently, 10–12% of OFRM veterans become involved in the criminal justice system, often due to related substance abuse issues.
Which brings us to a really difficult but important topic: law enforcement suicide.
Yes. An organization called Badge of Life estimated that more cops die of suicide than homicide by a factor of 2.3 times higher.
That's horrifying.
It is. The suicide rate for police officers is 4 times higher than the general population, with estimates of 7 and 19% of officers having PTSD. This points to a significant problem within the culture, a culture that needs to change from ignoring mental health issues to adopting a cradle-to-the-grave approach for officer mental health and suicide prevention.
That's a powerful call for cultural change, recognizing that our first responders are not immune. Now let's talk about developmental disorders, which are lifelong challenges, often present from childhood.
Right. Developmental disorders are conditions present since birth or childhood that prevent full social or vocational independence in adulthood and continue throughout life. We'll specifically look at autism spectrum disorders and intellectual disability.
What are the key behaviors associated with autism spectrum disorders, or ASD, that an officer might observe?
Individuals with ASD may exhibit a range of behaviors. These can include a fear of touch, repetitive behaviors like rocking, hand flapping, or making noises sometimes called stimming. Also, an insistence on routine, extreme anxiousness in new situations, and a tendency to become easily confused. They may also be impulsive and potentially aggressive without clear provocation.
And communication is often affected.
Profoundly. They may avoid eye contact, not answer questions directly, or echo words without providing an answer that's called echolalia. They might also have difficulty with the natural give and take of verbal exchange. Additionally, individuals on the spectrum may display restricted, repetitive patterns of behavior or interests, fixating intensely on a word, topic, or object, and becoming very distraught if it's removed.
So it's a very wide spectrum of manifestations, making each interaction unique.
Exactly. The severity ranges from severe, nonverbal, highly reactive to change, often with co-occurring intellectual disability, to mild, where individuals can function independently, hold jobs, maintain relationships. The common saying is, if you've met one person with autism, you've met one person with autism because the manifestations are so incredibly varied.
What are the best strategies for officers interacting with someone with ASD? How should they approach it?
Officers should be patient, calm, and detached, as this helps prevent agitation. It's crucial to avoid physical contact or limiting personal space, which can easily escalate things. If possible, interact with a trusted care provider or family member to determine the best approach.
And communication tips.
Use simple language. Illustrative materials might help. Repetition, praise, encouragement, and attentive listening can greatly assist. Give instructions or ask questions one at a time, and importantly, don't get entwined in delusional content if it's present.
Next, let's define intellectual disability, or ID, and what it means for law enforcement interactions.
Okay. Intellectual disability involves deficits in both intellectual functioning, like reasoning, problem solving, and adaptive functioning, the skills needed for daily life. This failure to meet developmental and sociocultural standards for personal independence must be diagnosed by age 18.
And it's different from mental illness.
Yes, it's a fixed mental condition that, unlike many mental illnesses, cannot be cured. Limitations can include deficits in communication, self-care, home living, personal safety, academic functioning, and occupational abilities. It exists on a spectrum of severity, usually measured by IQ alongside adaptive functioning.
So what are the most effective communication methods for officers when dealing with someone who has an intellectual disability? What cues might they see?
Officers should be aware of several potential cues. In criminal activity, the subject might appear older than others involved, act as a follower, readily confess perhaps due to a lack of understanding or suggestibility, or remain at the scene while others flee.
And in their speech or behavior.
Speech and language cues could include obvious speech defects, limited comprehension for their age, difficulty maintaining attention or describing facts logically. Social behavior cues might involve an adult associating primarily with children, ignorance of personal space, or non-age appropriate behavior.
How should officers adjust their questioning?
Patience is crucial. Repeat questions clearly. Use short, simple language. Speak slowly. Ask open-ended but uncomplicated questions rather than just yes or no questions, which can sometimes lead to inaccurate answers if the person just wants to please the officer.
Let's discuss the role and complications of psychotropic medications. These are often a vital part of treatment, but also present significant challenges for responders when people aren't taking them.
Absolutely. Psychotropic medication is any medication capable of affecting the mind, emotions, and behavior. These medications are often essential for effective treatment plans, helping manage symptoms like psychosis, anxiety, depression, ADHD, impulse control, mood swings.
So they help people function.
They provide symptom relief, enabling individuals to engage more fully in therapy, develop coping skills, and manage self-care. They can be life-changing.
But there are many reasons people stop taking them, which then becomes a challenge for law enforcement responding to a crisis.
Exactly. One major issue is simply access, lack of health insurance, the high expense of medications, lack of consistent mental health treatment. Just getting them can be hard.
And the side effects.
Unpleasant side effects are another common reason for discontinuation. Things like significant weight gain, severe constipation, sexual dysfunction, or that feeling of being dissociated or out of sync. Long-term, high-dose use can even, in some cases, lead to neurological damage.
And we mentioned people stopping when they feel better.
Yes, that's a primary cause of crisis incidents. They feel better, think they don't need it anymore, stop abruptly, and the symptoms return, sometimes worse than before. And critically, safety concerns arise from mixing psychotropic medications with other drugs or alcohol, or taking excessive doses, which can be lethal.
Finally, in this section, let's explore substance abuse disorders and co-occurring conditions. These are often deeply intertwined with mental health crises, complicating everything for first responders.
Definitely. A substance abuse disorder involves continued substance use despite significant related problems. Individuals often begin abusing substances as a form of self-medication, trying to treat underlying symptoms like depression, insomnia, or anxiety on their own.
But it backfires.
It often does. Prolonged abuse can cause chemical dependency or addiction, influencing consciousness, brain, and body functions. It can potentially cause permanent central nervous system damage, leading to psychological reactions classified as disorders in their own right.
And then when mental illness and substance abuse co-occur, which is common, right? It creates a much more complex situation.
Absolutely. It's called co-occurring disorders or dual diagnosis. Illegal drug and alcohol use is a primary concern for individuals with mental illness. These substances interact adversely with prescribed medications or are used for self-medication, leading to inconsistent medication absorption, dangerous chemical combinations, and a lack of medical monitoring.
So treatment needs to address both.
Yes, integrated mental health and substance abuse services are the most successful treatment models. But first, responders need to try and identify if a substance is involved in the immediate crisis.
Can you give us a quick overview of some of the drug categories and their general effects as officers might encounter them? Just the high-level impact.
Certainly. Think of central nervous system, CNS, depressants like alcohol, barbiturates, Xanax as hitting the brakes on the brain. You'll see incoordination, disorientation, sluggishness, slurred speech. Often like someone's drunk, but maybe not from alcohol. Overdose signs include shallow breathing, cold skin, rapid weak pulse.
Okay, what else?
Hallucinogens, like LSD or psilocybin, cause the user to perceive things differently. You might see body tremors, a dazed look, speech difficulty, maybe paranoia, poor perception of time and distance. The reality is altered.
And dissociative anesthetics, like PCP?
Yes. Dissociative anesthetics, like PCP or ketamine, inhibit pain by kind of disconnecting the brain's pain perception. This can lead to a blank stare, confusion, increased pain threshold, maybe unpredictable, potentially violent behavior, sensory distortions. It can also sometimes lead to excited delirium, a very dangerous state of extreme agitation and high body temperature.
That sounds incredibly dangerous. What about opioids or stimulants?
Narcotic analgesics, opioids like heroin, morphine, Oxycontin relieve pain, induce euphoria. Signs include depressed reflexes, drowsiness, droopy eyelids, maybe facial itching, slowed breathing. Overdose is a major risk, marked by slow, shallow breathing, clammy skin, possibly seizures or coma.
And inhalants.
Inhalants like glue, gasoline fumes, aerosols are breathable substances producing mind-altering effects. Look for bloodshot eyes, confusion, disorientation, flushed face, intense headaches, lack of muscle control, often an odor of the substance. Overdoses can cause seizures and coma.
What about cannabis?
Cannabis, marijuana, includes synthetics like K2 or spice. Symptoms can include body tremors, disorientation, maybe debris in the mouth, impaired perception of time distance, increased appetite, red eyes, possible paranoia, relaxed inhibitions. No known overdose level for THC itself.
And newer things like bath salts.
Right. Other substances like bath salts are often unpredictable mixes of chemicals. Behavior in overdose are hard to predict, can cause that idiopathic excited delirium, meaning it arises sort of spontaneously. It's important to remember it's rare to see someone intoxicated from just one substance. Often it's a dangerous mix, complicating the response.
Okay, now that we've laid the groundwork for understanding the mental health challenges, let's turn to the practical application. Crisis intervention itself, focusing on de-escalation and communication mastery. What's the overall goal here? It's not about diagnosis on the scene, right?
Precisely. The overall goal is not to diagnose the person or resolve their underlying mental health issues in that moment. Instead, the primary objective is to verbally diffuse the immediate situation to the best of your ability.
Just bring the temperature down.
Exactly. It's about bringing immediate calm to what is often a chaotic and potentially dangerous encounter.
And how is this achieved? Is there a structured process that officers are taught to follow?
Yes. There's a three-phase process that guides this. Phase 1 is safety, prioritizing the safety of the public, the subject, and the police officer. That always comes first.
Makes sense.
Phase 2 is stability, attempting to stabilize the person using verbal and nonverbal de-escalation skills. And Phase 3 is problem solving, trying to guide the person into a more rational frame of mind, lessening their emotional reactivity to increase the likelihood of future compliance and resolution.
So safety, calm, then solution. It's a logical progression.
It is, designed to reduce immediate harm and open the door to getting them help.
The Police Executive Research Forum, PRF, has a critical decision-making model that seems highly relevant here. Tell us about that.
Right. The PRF Critical Decision-Making Model, or CDM, it was adapted from specialized police tactical units like SWAT and also UK police practices. It combines critical thinking with tactical concepts like distance, cover, and time.
So it's strategic thinking applied to patrol.
Exactly. And at its core, it's grounded in the ethical values of the department and the policing profession, emphasizing de-escalation as a core principle. The key takeaway is to not rush into situations unless absolutely necessary. Patients can significantly increase the safety of everyone involved.
Slowing things down buys time to think.
It does. The focus should always be on calming the situation and minimizing the level of stress, buying time to think and react thoughtfully, not just instinctively.
That initial engagement must be crucial. How should an officer start to build that crucial early connection when they first arrive?
A good introduction is key. Use your name and the person's name if you know it. Being called by their name can help them refocus on reality and feel acknowledged as a person.
Not just a subject.
Exactly. Officers should also model the desired behavior through their own interactions, proper tone, calm emotional level, using peaceful phrases. Remember, emotions are contagious. A calm demeanor from the officer can help de-escalate the person in crisis.
And how quickly can an officer assess the situation for mental health status without being a diagnostician? Is there a quick way?
Yes, officers can use a quick 3-point assessment to get a rough determination of a subject's mental health status. First, assess their level of comprehension. Do they understand you? Can they follow simple instructions? Answer basic orientation questions: person, place, time. Does their speech make sense? How is their speech rapid, slow, slurred?
Okay, comprehension first.
Second, observe their behavior. How is their self-care, disheveled, appropriately dressed? Hygiene. When did they last eat or drink? What's their physical coordination like? Are they complying? Is non-compliance maybe due to mental health issues, not defiance?
And third.
Third, gauge their emotion. What is their prevailing emotional state? Anger, sadness, euphoria, anxiety? Is it appropriate to the situation? Are their emotions fluctuating rapidly? Are they exhibiting extreme paranoia? Is their facial expression consistent with their mood? These quick observations provide crucial clues.
PRF also provides additional guidelines for these interactions. What are those beyond just assessing the person?
PARF advises officers to exercise immense patience. Do not rush the person or crowd their personal space. Any attempt to force an issue can quickly backfire into violence.
Give them space.
Yes. If the situation is secure and no one can be harmed immediately, officers should adopt a non-threatening, non-confrontational stance, maybe standing at an angle, hands visible.
What about outbursts?
Emotionally charged or even violent outbursts are often short-lived. It's usually better to let them dissipate naturally rather than physically engaging someone under extreme emotional stress. Bizarre behavior alone is not a reason for physical force. What truly works best is patience and communication.
Rapport is key.
The tone and outcome of an interaction are almost always impacted by the degree to which an officer can build rapport.
So much of this revolves around how we interact with people, often under extreme duress. Dr. Thompson's 5 universal truths of human interaction seem to distill this perfectly. Can you remind us of those?
They offer a powerful framework applicable across cultures. The truths are: 1. All cultures want to be treated with dignity and respect. 2. All people would rather be asked than told what to do. 3. All people want to know why they are asked or told to do something. 4. All people would rather have options than threats. 5. All people want a second chance to make matters right.
Dignity, respect, explanation, options, second chances.
These truths are fundamental to building positive interactions, especially in crisis situations, because they tap into basic human needs for autonomy and understanding.
Dignity, respect, options. These are powerful tools for building rapport and trust, which is the very foundation of de-escalation. How do officers actively build that trust in a chaotic moment? What are the tactics?
Honesty and sincerity are absolutely paramount. Individuals experiencing mental health issues can be highly attuned to communication nuances. They can easily sense dismissiveness, ulterior motives, condescension, or negative nonverbal cues.
So be genuine.
Be genuine. Officers should use the person's preferred name, be patient, try to match their conversational speed, and maintain a calm tone of voice. Crucially, they should never minimize or discount the subject's point of view, even if it seems illogical.
Validate their feelings, even if you don't agree with the facts.
Exactly. Validate any positive actions they have taken, and employ tactical transparency, forewarning them about what will happen next. That builds confidence.
Can you give an example?
Sure. You have been very straightforward with me, and I am going to be straightforward with you. You are going to have to be handcuffed when you ride in the car for your safety and for mine. This manages expectations and builds trust by being upfront.
So clear communication, both verbal and nonverbal, plays a huge role. It's not just about the words.
Absolutely not. Good, non-confrontational eye contact, minimizing distractions, actively listening without interrupting, these are vital. Validating and empathizing, along with engaged body language like leaning forward or nodding, shows genuine interest. It's not just what you say, but how you say it and what your body language conveys that truly communicates your intent.
And what if rapport gets fractured by a misstep? Can it be repaired in that moment?
Yes, but it requires effort and humility. Rapport can be fractured by judgment, dishonesty, failing to follow through, aggression, a dismissive tone, disinterest, labeling, being patronizing.
Easy to do under pressure?
Very easy. To repair it, the officer must acknowledge what went wrong, take responsibility for their part, apologize sincerely, express sincerity, and take corrective action if possible. It's about demonstrating genuine commitment to de-escalation even after a mistake.
And nonverbal cues are critical, especially when someone might be struggling to process verbal commands due to their mental state.
Exactly. PRF highlights 3 categories of nonverbal communication. Friendly, helpful behaviors, conveying safety, respect. Aggressive, hostile behaviors, communicating distance or danger, like blading stance or hand on weapon. and ambiguous behaviors, which are open to interpretation.
And ambiguous is bad here.
For individuals in crisis, if a posture isn't overtly friendly, it's often interpreted as dangerous. They may struggle with verbal commands, but can often read your nonverbal cues and sense your level of concern, empathy, and genuineness. Their survival instincts are hyper-tuned.
What's the best approach when faced with verbal abuse, which seems almost inevitable in these highly charged situations? Just ignore it.
Pretty much, officers are advised to ignore demeaning language and not give weight to those statements. Don't take the bait. Instead, the focus should be on deflecting and redirecting the individual back to the situation at hand.
How do you do that?
Phrases like, I appreciate that, but, oh, I understand that, but, or, I'm sorry you feel that way, but, can be effective in guiding the conversation back without engaging in the abuse or getting defensive. It keeps the interaction professional and goal-oriented.
And to gather all this crucial information, there's the 80-20 rule you mentioned earlier.
Right, the 80-20 rule. Listen for 80% of the time, talk for 20%. This ratio enables officers to gather more information, understand the situation fully, and make an ongoing, accurate situational assessment, rather than just jumping in or waiting for their turn to speak.
It's about absorbing, not just responding.
Exactly.
That leads us perfectly into the APS model of communication, a practical framework for putting all these techniques together. Can you walk us through it? LEAPS.
Sure. The APS model is a cornerstone of crisis intervention communication. It stands for listen, empathize, ask, paraphrase, and summarize.
Okay, let's start with L.
Listen. Listening is fundamental. Most individuals don't truly listen. They're just waiting to reply. Failing to listen prolongs confrontation and prevents a full understanding. Active listening allows you to recognize both the content of what's being said and the emotion behind the message.
So listen for feelings, too.
Yes. If someone is angry, allowing them to ventilate can help diffuse that anger while you gather information. Let them do most of the talking initially. It provides an opportunity for them to vent and for you to learn how best to intervene.
Okay, L is listen. Then E, empathize.
Empathy requires you to try and put yourself in the other person's shoes, consider the problem from their perspective, even if it seems irrational to you.
How do you show empathy?
You can often express it through a statement of understanding, like, it sounds like you feel betrayed, or that must be really painful for you. You don't have to agree with their point of view, just verbalize your understanding of their feelings. This demonstrates genuine listening, shows you care, builds trust, all while remaining non-judgmental.
L, listen. E, empathize. Next is A, ask more questions. This is where you really dig in for information.
Exactly. This is another opportunity to show you're interested and want to help them problem solve. Use the basics: who, what, when, where, how. Asking questions can also help identify if the person is ready for assistance and can help diffuse some of the emotional intensity, shifting them towards a more rational space as they engage their thinking brain.
Okay. Then P, paraphrase. What does that involve?
To paraphrase means to reiterate what they've said, but in your own words. For instance, okay, let me be sure I understand what you've said. You feel like X because of Y, is that right?
Why is that helpful?
This either provides confirmation that you understood correctly, which strengthens rapport, or gives them an opportunity to correct your perception, which also strengthens rapport because it shows you're trying to understand. It ensures precise understanding and allows you to subtly guide the conversation. Always end by asking, did I get that right, or did I miss anything?
LEA. Finally, S, summarize.
This is where you bring it all together. You summarize their point of view, the options available, and what will happen next. It creates clarity and a path forward. The LEAPS process is dynamic. You might loop back, listen more, ask more questions, but the goal is to lead towards resolution.
So what are some pro-LEAPS phrases and behaviors officers should use? And maybe more importantly, what should they absolutely avoid? What are the anti-LEAPS?
Okay. Pro-LEAPS phrases include things like, excuse me, sir, can I speak with you? What would you like me to call you? For your safety in mind, what's wrong? What can I do to help? Very respectful and open.
And behaviors.
Pro-LEAPS behaviors involve modeling calm, non-threatening behavior, being patient, restating messages clearly and simply, using the person's preferred name, giving instructions one at a time, avoiding getting hooked into delusional content or trying to argue about hallucinations, allowing ample personal space, and minimizing distractions like sirens and lights if possible and safe.
And on the flip side, the anti-LEAPS things to avoid.
Definitely avoid. Calm down. That almost never works. Also, what's your problem? You people, come over here, sounds demanding. I'm not going to tell you again because these are the rules. Or the classic, Because I said so.
Yeah, those have like instant escalation buttons.
They really are. They're almost guaranteed to escalate a situation and shut down any chance of positive interaction or building trust.
There are also some more advanced techniques that reinforce the Lee's PS model, helping officers to move from simple communication to actual influence. Can you touch on those?
Sure. One advanced technique involves reflecting statements. These are neutral responses like, I see, or tell me more about that, or even just nodding, designed to encourage the subject to continue talking without you interjecting opinions.
Keeping them talking.
Exactly. Another is using I statements versus you statements. You statements like, you are not listening, sound accusatory and create defensiveness. I statements such as, I understand you are frustrated and upset. I want to help you resolve this situation, but here's what I will need from you. Take responsibility, build rapport, and ease communication.
Framing it from your perspective.
Yes. Using emotion words can also help. Mr. Smith, I feel nervous when you wave that object around. Please put it down so we can talk.
And we touched on tactical transparency earlier. How does that fit in as an advanced technique, especially when officers might need to take action?
Right. Tactical transparency means explaining an action before initiating it so the person knows what to expect. Okay, I need to check the room for everyone's safety now. This is especially useful for individuals with PTSD, ASD, or those who are highly reactive, as it clarifies intentions and conveys a mutual interest in safety.
But only when safe.
Absolutely. This technique is used only when the situation is relatively safe, with adequate backup and no immediate sign of impending violence. Officer safety is always paramount. The overall goal here is to move from rapport to influence. You can't really get influence without rapport first.
Makes sense.
So, project empathy, paraphrase for meaning, use open-ended questions. Build rapport with simple life questions if appropriate: home, work, school, hobbies. Be aware of hooks, what motivates them, and potential triggers. Provide options whenever possible. Make clear, single requests.
And ultimately, all of this is aimed at achieving voluntary compliance, right?
Yes, voluntary compliance ideally comes after you've established influence through rapport. Thank and praise cooperation, even for small baby steps. Requests should often be made incrementally. Can you take the knife away from your neck? Pause. Okay, now can you set it down next to you?
Breaking it down.
Exactly. Finally, using I when because statements for instructions can be very effective. Before we can get you some help, I will need you to step outside with me because paramedics need to check on you safely. It summarizes the situation and explains the why in a clear, collaborative, and respectful way.
Let's shift now to a critical and very sensitive topic: suicide prevention. The grim reality of suicide statistics really underscores the urgency of this intervention skill for first responders.
It truly does. The numbers are heartbreaking. Between 2005 and 2009, just in Texas, over 12,000 people were lost to suicide. It was the top cause of injury death for all ages here. Nationally, it's staggering around 121 suicides per day.
1 every 12 minutes or so.
Roughly, yes. 1 person every 11.9 minutes. It's the 10th leading cause of death overall in the U.S. and the second leading cause of death among 15-24-year-olds.
And there are demographic factors.
Yes. Men die by suicide about 3.3 times more often than women, although women attempt suicide about 3 times more often. White males accounted for 7 out of 10 suicides in 2015. And a particularly tragic statistic we mentioned earlier: 18-22 veterans commit suicide daily.
Just devastating numbers. What methods are most common?
Firearms accounted for nearly half, 49.8% of suicide deaths in 2015, followed by suffocation, 26.8%, and poisoning, 15.4%. These numbers highlight the devastating scope of the problem.
What are the specific risk factors that can help officers recognize an increased suicide risk when they're on the scene with someone in crisis?
There are several quantifiable risk factors to look for. Demographically, being male, particularly aged 15-34, increases risk statistically. Mental health conditions like depression, substance intoxication, and especially previous suicide attempts are very strong indicators.
What about their emotional state?
Feelings of hopelessness, helplessness, and powerlessness are major red flags. Having a highly specific plan, clear intent to act, and having the means readily available to complete the plan, these are critical indicators of imminent danger.
And social factors.
Yes, a lack of a support system or connection to loved ones, recent significant losses, divorce, child custody issues, retirement, death of a loved one, loss of job all elevate risk. And finally, if an individual expresses feeling they are worth more to their loved ones dead than alive, perceiving themselves as a burden, that's a very significant warning sign.
Recognizing those risk factors is essential. But what about protective factors? What can actually help safeguard someone against suicide, acting as a buffer?
Protective factors build resilience and are vital. These include having a healthy, active support system, actively avoiding drugs or alcohol, having a connection to a spiritual faith or community, stable employment, financial stability, and good access to local health services and effective mental health care.
Personal skills matter too.
Absolutely. Strong problem-solving skills, positive contacts with caregivers, cognitive flexibility, the ability to think differently about problems, positive coping skills, and generally good physical and mental health. These elements create a web of support that can help an individual navigate a crisis.
So, when an officer suspects a suicide risk, how should they conduct a suicide risk assessment? What are the key questions they need to ask, however difficult they might be?
The assessment focuses on 4 key areas, easy to remember: plan, method, means, and intent.
Okay, plan first.
Plan. Determine if there's a specific plan. Ask directly, have you been thinking of hurting or killing yourself? If yes, have you made a plan? What arrangements or preparations have you made? Get specifics.
Second, method.
Method. Have you decided upon a method or a location for your plan? Again, specifics matter.
Third, means.
Means. Do you have the means readily available to carry out the plan or chosen method? Do they have the pills, the weapon, access to the location right now?
And finally, intent.
Intent.
Yeah.
Assess their determination. Listen for cues of doubt or certainty in their voice and words. Don't shy away from direct questions like, how certain are you that this is the decision you want to make? Or, on a scale of 1 to 10, how likely are you to act on these thoughts?
It feels counterintuitive, but asking directly doesn't increase risk.
No, that's a myth. Asking directly and compassionately opens the door for communication and shows you're taking them seriously. It can actually decrease risk by allowing them to talk about it.
Are there any additional considerations when evaluating the level of suicidal risk?
Yes. Officers should assess if the person is exhibiting active symptoms like psychosis, substance intoxication, or extremely agitated or withdrawn behavior, which can indicate acute distress and higher risk.
Does the type of stressor matter?
It can. Consider the nature of the current stressor. A chronic stressor, like a terminal illness or intractable pain, often poses a greater long-term risk than an acute temporary one, though both need immediate attention.
And practical help.
Officers can and should offer practical suggestions, provide suicide hotline numbers like 988, give information on how to seek treatment, maybe even assist in locating immediate resources if feasible and safe. It's also helpful to consider existing social supports. Can family, friends, neighbors, or religious leaders be contacted to provide immediate support? These connections can be life-saving.
Now, let's explore the legal frameworks that guide police intervention in mental health crises, particularly focusing on the Texas Health and Safety Code. This is where CIT intersects directly with the law, providing specific guidelines for officers.
Indeed. A critical component here is involuntary commitment, specifically what's known as warrantless apprehension, sometimes called a police officer emergency commitment or detention.
Warrantless apprehension.
Okay. Under the Texas Health and Safety Code, Section 573.001, a peace officer may take a person into custody without a warrant under specific conditions.
What are those conditions?
The officer must have reason to believe the person is mentally ill. A&D poses a substantial risk of serious harm to themselves or others unless immediately restrained, and there isn't sufficient time to obtain a warrant.
So mental illness plus immediate danger and no time for a warrant.
Exactly. It's a high bar designed for emergency situations.
How is substantial risk actually demonstrated in a legal sense? What does an officer need to see?
Substantial risk can be shown by the person's behavior, overt actions, threats, or by evidence of severe emotional distress and mental deterioration, to the point that the person simply cannot remain safely at liberty.
And where does the officer's belief come from?
The officer's belief can come from a credible person's report, like a family member, a therapist, or from the apprehended person's own conduct or the circumstances the officer observes directly. It's about observable behavior and reliable information indicating danger.
And what are the specific actions an officer must take once they've apprehended someone under these circumstances? That can't just be a trip to jail, right? That seems counterproductive.
Absolutely not, and the law is clear on this. The officer must immediately transport the person to the nearest appropriate inpatient mental health facility or a suitable facility designated by the local mental health authority if an inpatient facility isn't available.
So a hospital or clinic, not jail.
Right. Crucially, a jail or similar detention facility is not deemed suitable except in extreme emergencies, and even then, detained persons must be kept separate from the general inmate population.
Okay. What else must the officer do?
They must immediately inform the person, orally, in simple terms, of the reason for detention. And within 24 hours, they must provide written notice of their rights. Furthermore, officers may immediately seize any firearm found in the person's possession for safety.
And there's paperwork.
Yes, the officer files a notification of detention. This document serves as a magistrate's application for emergency apprehension and detention. Importantly, this is a civil court order, emphasizing the medical, not criminal, nature of the intervention.
So there are clear protections and procedures in place for the officers as well, not just for the individual in crisis.
Yeah.
What about liability?
Yes, the Texas Health and Safety Code, Section 571.019, provides a limitation of liability. Individuals acting in good faith, reasonably, and without negligence are not civilly or criminally liable. This protection is crucial for officers making difficult decisions in high-stress situations.
And the law pushes for the least restrictive option.
It does. There's the principle of the least restrictive alternative, Section 571.004. Treatment should be available, provide the greatest possibility of improvement, and be no more restrictive of the person's liberties than necessary for effective treatment and protection from danger.
But sometimes people just cycle through the system, don't they?
Unfortunately, yes. Inadequate treatment prior to release, often due to resource limitations, can lead to what some call the circular detention process or the revolving door. Individuals cycle back through the criminal justice system because they didn't receive sufficient care or follow-up, becoming repeat offenders when they should be ongoing patients.
This sounds like exactly where diversion programs and mental health courts come in offering pathways to treatment rather than just repeated incarceration trying to break that cycle.
Exactly. Diversion means guiding individuals away from the traditional criminal justice system and incarceration toward different interventions, primarily mental health treatment and support services.
And legislation supports this.
Yes, Senate Bill 1849, which we mentioned earlier, specifically mandates local mental health authorities in Texas to incorporate jail diversion strategies, particularly for adults with schizophrenia and bipolar disorder, precisely to reduce their involvement with the criminal justice system.
What are the key goals of these jail diversion efforts? What kind of impact are they aiming for?
The goals are broad and impactful. The decriminalization of persons with mental illness, increased public safety, reduction of inappropriate incarceration, reduced violence and victimization, both by and against people with mental illness, decreased taxpayer costs associated with arrest and incarceration, and lower recidivism rates.
Do they work? Is there evidence?
Yes, evidence suggests they can be very effective. For example, a pre-arrest diversion program in Florida back in 2013 saw an 80% completion rate among participants, and only 6% were rearrested within a follow-up period. That's a powerful argument for these programs providing support instead of just punishment.
So there are different types of diversion, before and after arrest.
That's right. Pre-arrest diversion involves diverting someone before an arrest or charges are even made, perhaps sending them directly to a mental health treatment facility or hospital instead. This can be ideal for someone experiencing a crisis related to their illness, especially a first-time low-level offender who would be significantly hampered by an arrest record.
And post-arrest.
Post-arrest diversion, also known as pretrial diversion programs, are typically voluntary programs for offenders already charged. They offer an alternative to traditional criminal case processing. Successful completion usually results in lessened or dismissed charges, avoiding a conviction.
And mental health courts take this concept even further, right? Integrating judicial oversight with treatment.
They do. A mental health court is a specialized court docket. It combines judicial supervision with community mental health treatment and other support services like housing or job assistance. Its aims are to reduce criminal recidivism, improve the quality of life and treatment participation for individuals with mental illnesses, and ultimately reduce court and corrections-related costs.
Are there different kinds?
Yes, these specialized courts also include things like substance abuse courts and veterans courts, which specifically take into account a veteran's military history, PTSD, TBI, and other unique considerations, offering more tailored support.
Are these courts effective, and who typically participates? How many are there?
They've shown significant effectiveness. They grew rapidly from just 4 nationwide in 1997 to over 300 by 2017. Studies show offenders completing mental health court programs have a much lower recidivism rate than their peers in the traditional system, sometimes cited as low as 20% versus maybe 72% for similar offenders not in the program.
Who ends up in these courts?
The majority of participants have a serious mental illness, often alongside a co-occurring substance abuse disorder. Incentives for participation and sanctions for noncompliance are tailored to their specific charges, history, and needs. Referrals typically come from defense attorneys, judges, jail staff, or sometimes family members, all recognizing the need for a therapeutic rather than purely punitive approach.
Finally, let's talk about community and referral resources. These seem crucial for bridging the gap between that initial crisis intervention and long-term support. Because the officer's intervention is just the start, isn't it?
Absolutely. It's only the beginning. But the reality is the quality and availability of mental health treatment options vary significantly by location, community priorities, and, frankly, budgeting constraints. Resources are often in short supply. High medication costs or a lack of healthcare access can be huge barriers, even if someone wants help.
Are providers always willing to work with the justice system?
Sometimes there are challenges. Mental health providers can sometimes be reluctant to participate in criminal justice-initiated programs due to, perhaps, stereotypical concerns about the individuals involved, or just a lack of experience coordinating with law enforcement or courts. Building those bridges takes effort on both sides.
So what can an officer do on the scene to help connect someone to resources? Even if the system's imperfect, how can they bridge that gap?
Officers can start by inquiring if the person already receives mental health treatment, or if they have contact information for a provider or family member who might be involved in their care. While providers are limited by patient confidentiality, HFA, officers can provide information to the provider and ask for guidance on how to proceed, which can be immensely helpful.
So communication can flow one way, at least?
Often, yes. It's also really wise for officers to proactively visit their local hospital emergency rooms to understand their specific protocols for mental health emergencies. Talk to local EMS crews and mobile crisis outreach teams, or MCOT if their area has them. Building these local relationships and understanding the pathways to care before a crisis hits is key.
And for the public listening, or officers who might not have internet access readily available in the field, are there hotlines or specific resources that are easily accessible?
Absolutely. The Texas Department of Health and Human Services website is a good starting point for online resources. But for more immediate or offline access, several crucial hotlines exist.
Like the suicide hotline.
Yes, the National Suicide Prevention Lifeline is 1-800-273-TAC-8, and now it's also accessible nationwide by simply dialing or texting 988. That's a huge step forward.
988. Easy to remember. What else?
There's the Alzheimer's Association hotline at 1-888-572-8566. And for general mental health and social service referrals in Texas, 211 or www.211texas.org is often the best, easiest, and most comprehensive resource for finding local services, housing, food, counseling, everything.
Got it. And for veterans?
For veterans in crisis, the Veterans Crisis Line is vital. 1-800-273-8255 and press 1 or text 838-255 or visit veteranscrisisline.net. These numbers are truly vital lifelines, providing immediate support. #TAG outro.
Well, we've certainly navigated the complex landscape of mental health crises today. We've gone from the urgent need for specialized training like CIT to understanding specific conditions like PTSD, autism, mood disorders, and the vital role of communication models like LEPS, plus the legal frameworks guiding intervention.
Yeah, it's become really clear, hasn't it? Recognizing the signs, effectively employing de-escalation techniques, and crucially connecting individuals to appropriate resources. It can truly transform outcomes.
It enhances safety for everyone, the public, the officers, the person in crisis, and it helps build stronger community trust, which is so needed.
This deep dive really highlights how multifaceted these issues are, though. You have the human element, the individual suffering, combined with systemic challenges like the legacy of deinstitutionalization and those persistent gaps in healthcare access.
Makes it a persistent societal issue.
Absolutely. It demands ongoing attention and, frankly, innovative solutions. It's not just a police problem, it's a community problem. It requires a community response.
And that leads perfectly to our final thought for you, our listeners, to mull over. Considering the profound impact of deinstitutionalization and the ongoing challenges in mental health care access, This deep dive raises an important question for all of us. What responsibility do we, as informed members of our communities, bear in advocating for better mental health infrastructure and ensuring that compassion and comprehensive care become the standard response to those in crisis, long before law enforcement even gets the call?